Hello, my name is John Tsai, and I'm one of the nephrologists here at the UCI School of Medicine. Over the next 5 videos, we will delve more deeply into renal physiology, specifically handling of electrolytes and some of the endocrinological features of the kidney. I'll be splitting up the content in several different lectures, but I'll start off by discussing salt and water regulation along with the importance of the corticomedullary osmotic or concentration gradient in this video. This will be followed by a couple of videos on how our kidneys handle potassium and acids that are generated as metabolic byproducts. And finally, we will wrap up with our video on some of the hormones that the kidney produces and others that affect the renal perfusion along with blood pressure and volume regulation. Lastly, to solidify your knowledge and apply these concepts to clinical cases, we have some case studies for you. Recall that our kidneys are integral at performing 3 different functions. The first is electrolyte homeostasis. The second is water balance, and the third is getting rid of excess toxins. While it would be nice if we had a system where we could only get rid of any extra potassium or extra water from the body, it is the third function, getting rid of toxins, that biology has mandated us to filter out all of our serum and then produce a seemingly complicated process to reabsorb all that nutrients back into our body that we need through the tubules. You can imagine that if we only had a system to actively transport a toxin out of the body, we would not have any capability of getting rid of a toxin that we had never seen in our life before and didn't have an active transporter in our kidney to handle. Hence, even though this system is circuitous and complex, it is an incredible system that allows us for all 3 essential functions through the careful orchestration of pathways through the nephron, and it is these features that makes nephrology such an interesting field. Let's first review the kidney anatomy. We have 2 kidneys, a left and a right, with blood supply that branches off of the abdominal aorta. The left and the right kidney renal arteries supply the kidneys with about 20% of the cardiac output, while the renal vein brings that filtered and clean blood back to the inferior vena cava. Urine is produced as a byproduct of renal processes in the nephrons and then gets collected in the renal pelvis in the middle of the kidney before being sent to the bladder for storage through the ureter prior to elimination. There are 2 main sections of the kidney, the renal cortex and the renal medulla. The renal cortex contains the filtration aspect called the glomerulus. The renal medulla mostly contains the tubules, especially the long loops of Henle that make up the renal pyramids and the papillae. You will also notice some other areas of the kidney, such as the renal columns, which are sections between the renal pyramids, and the major and minor calyces, which are the initial parts of the urinary collecting system once it leaves the renal medulla on its way to the ureter. You can also see the hilum, which is the aggregate of the blood vessels, and the ureter that lead into and out of the kidney. Interestingly, since kidney function is so important to life, functionality is duplicated, and we can in fact live with only 1 kidney. This is true in patients who have donated a kidney, for example, or those who have received a kidney transplant. We only need to take 1, and patients only get 1 kidney when they get a kidney transplant. So long as you take good care of that kidney and prevent damage over time, 1 kidney can last a lifetime. Kidney donation is an incredible gift of life for an individual since it allows them to live life without needing to be hooked up to a dialysis machine as a form of kidney replacement therapy. But I digress. Let's get back to talking about renal physiology. Let's now delve into the individual nephron and the nitty-gritty of renal physiology. I'll keep referring to this diagram throughout the course to map out where things are and where things go. It gets very complicated quickly, but hopefully with a high-level overview, we can make some sense out of this incredible system. First, we start off on the left side, where we have the glomerular filtration. Almost all our serum is filtered out through this glomerulus, including everything included in the serum, such as electrolytes or small molecular substances. Everything goes through the filter, and it is up to the remainder of the nephron to reabsorb or pick out certain bits and pieces to make our final urine product, consisting of our waste products and excess electrolytes. Right after our glomerulus, we have our proximal convoluted tubule, which is responsible for reabsorbing about 80% of the entire filtrate, including water and all of our major electrolytes. If you were to guess where in the tubule anything is mostly absorbed, you could answer the proximal convoluted tubule, and you would almost always be correct. We then proceed down the loop of Henle, for which the most important function is to create the medullary concentration gradient. In our discussion on water handling, we will talk more about how this medullary concentration gradient allows for water reabsorption and retention in conjunction with aquaporin channels, or channels that allow water to be absorbed, later found in the cortical collecting duct. After the loop of Henle, we have the distal convoluted tubule that begins to fine-tune our electrolytes. And lastly, we have the cortical collecting duct, which is where we really fine-tune our electrolyte handling and is our last chance at reabsorbing any of the substances we need before the point of no return, when the urine enters in the calyces and subsequently into the ureters. While the cortical collecting duct handles only about 2 to 5% of the electrolyte load, that 2.2 to 5% is important given that healthy kidneys filter on average about 100 to 120 milliliters per minute, which translates to about 144 liters per day. Obviously, we don't pee out that much, and if we did, we would be in a lot of trouble. So it is that 1 to 3 liters of urine that we make every day that is the remnants of all the intricacies of the kidney that allows our body to continue functioning. Now that you've had a bird's eye view of the nephron, we can begin to talk about the individual electrolyte handling and the different areas of the kidney that are involved. First, let's talk about how sodium is handled in the kidney. In the proximal tubule, remember that most of the sodium that is filtered is reabsorbed here. There are 4 main mechanisms to allow for this to occur on the tubular side, including sodium cation transporters, such as the sodium glucose transporter as seen here in this figure. Sodium is also reabsorbed as a byproduct of bicarbonate reabsorption, which we'll be discussing more in depth when we discuss about how our kidneys handle acid. Sodium is also reabsorbed as a byproduct of ammoniogenesis, with the secretion of ammonia into the lumen. And we will also discuss the importance of ammonia as a buffer in our urine. And finally, sodium is reabsorbed as a byproduct of excretion of protons when the proximal tubule tries to get rid of excess acids. If you take anything away from the slide, it is that the majority of sodium is reabsorbed in the proximal tubule, and the sodium cation transporters, as well as the sodium bicarbonate exchange with the sodium hydrogen exchanger, or NHE3. On the other side, the blood side of the proximal tubule, the sodium-potassium ATPase is integral in ensuring the sodium is returned back to the blood, but it's also enhancing our electrochemical and diffusion gradients that allow more sodium to be reabsorbed through the previously mentioned mechanisms. We also have to remember that chloride is also passively absorbed through the pericellular processes, driven mainly by the electrochemical gradient that is created with the active transport of sodium across this luminal membrane. Through all of these mechanisms, essentially 2/3 of our sodium, 2/3 of the chloride, and 2/3 of the water secreted in the glomerulus gets reabsorbed in the proximal tubule. Now let's talk about the other portions of the nephron and the remaining 1/3 of sodium reabsorption. The descending limb of the loop of Henle does not necessarily partake in the movement of sodium, but is important at reabsorbing water and creating concentrated filtrate. It is also the site of urea secretion, as not only is urea filtered in the glomerulus, but it also secreted in this portion of the nephron, allowing for greater urea secretion. What makes descending loop important is that the removal of water allows a high sodium concentration that sets up the ascending limb of the loop of Henle to actively transport sodium molecules out and generate the medullary concentration gradient. Now we have arrived at the ascending limb of the loop of Henle, which represents reabsorption of about 25% of the filtered sodium load and can be divided into 2 different segments. In the first, or the thin segment, sodium chloride is passively transported down its concentration gradient. Remember, the descending limb sucked out all the water, but none of the solute, making for a very highly concentrated filtrate. As the concentration of this filtrate decreases into the second or thick portion of the loop, active transport mechanisms are now in place to drive even more sodium out. Overall, there are 2 main effects of the loop of Henle. The first is we end up with a similar concentration of filtrate entering the loop of Henle, and more importantly, the generation of what is the medullary concentration gradient, or the cortical medullary osmotic gradient. When we talk more about water regulation, this medullary concentration gradient will play a large role in helping provide the osmotic gradient needed to reabsorb free water. Let's see an explanation of how the formation of this medullary concentration gradient is, and hopefully you can see why it's so important to the conservation of water. Imagine you are a tiny drop of filtrate entering into the loop of Henle. At this point, the filtrate is roughly the same concentration as plasma, about 300 milliosmoles per liter. Now the kidney faces a challenge. If the body becomes dehydrated, the kidney must conserve water, but water will only move if there's a concentration gradient or osmotic gradient pulling it out. so the kidney creates one. Deep inside the renal medulla, the kidney builds an environment that becomes progressively saltier and more concentrated. The deeper you go into the medulla, the higher the osmolality becomes. This is called the medullary concentration gradient, and the structure primarily responsible for creating this gradient is the loop of Henle. The two limbs of the loop of Henle behave very differently. The descending limb is highly permeable to water, but it does not actively transport salt. The ascending limb is the opposite. It actively transports sodium, potassium, and chloride through the NK-CCl transporter, but it is impermeable to water. This difference is what allows the kidney to generate the gradient. Let's follow the filtrate. As the filtrate travels down the descending limb, it encounters an increasingly concentrated medullary interstitium. Because the surrounding medulla is so salty, water leaves the descending limb by osmosis. As water exits, the tubular fluid becomes progressively more concentrated. Then the filtrate rounds the bend and enters the ascending limb. Now something very important happens. The thick ascending limb actively pumps sodium, potassium, and chloride out into the medulla, but because the segment is impermeable to water, water cannot follow. So salt leaves, but water stays behind. This dilutes the tubular fluid while simultaneously making the medulla more concentrated. This is why the thick ascending limb is often called a diluting segment. Now imagine this process occurring continuously while new filtrate keeps entering the nephron. As more salt is pumped out of the ascending limb, more water leaves the descending limb, and over time a small difference in concentration becomes multiplied along the entire length of the loop. This process is called countercurrent multiplication. Countercurrent refers to the opposite direction of the flow in the two limbs, and multiplication refers to how a small gradient becomes amplified into a very large one. Eventually, the deepest portions of the medulla can reach osmolarities of up to 1200 milliosmoles per liter. Now, this gradient becomes incredibly important later in the collecting duct. When ADH is present, aquaporin channels are inserted into the collecting duct. Water can then leave the collecting duct and move into the hypertonic medulla. As the water is reabsorbed, urine becomes concentrated. Without the medullary gradient, ADH would not be able to conserve water effectively. The kidney would lose massive amounts of free water. There are two additional players that help maintain this gradient. First is urea. In the inner medulla, urea diffuses out of the collecting duct and contributes significantly to the hypertonicity of the medullary interstitium. This process is called urea recycling. Second is the vasa recta. The vasa recta are specialized capillaries that run parallel to the loop of Henle. Their job is to preserve the gradient without washing it away. Because blood flows slowly through these hairpin-shaped vessels, they function as countercurrent exchangers. This allows the kidney to maintain the medullary osmotic gradient efficiently. I know there's a lot of detail that we can go into regarding urea cycling in the vasa recta, but for the purposes of this course, we'll try to keep it simple. You can always explore more in depth online. Clinically, this physiology becomes very important. Loop diuretics block the NK-CCl2 transporter in the thick ascending limb, and as a result, the kidney cannot establish the medullary concentration gradient effectively, or the medullary concentration gradient is disrupted. Without this gradient, water reabsorption decreases and urine output increases. And this is why loop diuretics are such powerful diuretics. So ultimately, the medullary concentration gradient exists because the ascending limb pumps salt into the medulla while remaining impermeable to water. The descending limb allows water to leave, and continuous countercurrent flow amplifies the process along the nephron. This elegant system allows the kidney to conserve water and produce concentrated urine when the body needs it most. Let's continue moving on the nephron to the distal tubule. We start to get into the fine-tuning of sodium when we enter the distal tubule, but it isn't until we get to the collecting duct segments that hormonal regulation starts to play a key role in sodium regulation. In the distal convoluted tubule, about 5% of sodium is reabsorbed, mainly through the sodium chloride transporter that we see on the left-hand side of this diagram. Again, the NAK ATPase remains a key player in setting up the electrochemical gradient that allows for sodium to be reabsorbed. Let's stop here to review the most important channels you should know. First, remember that sodium is reabsorbed in the proximal tubule via the sodium cation cotransporters, especially the sodium glucose cotransporter, or SGLT. The class of drugs called SGLT2 inhibitors block the action of this channel, which results in increased urinary sodium and glucose as their primary effects. The sodium hydrogen exchanger is also an important player, known as NAG3. When we move to the ascending loop and the distal convoluted tubules, the NAK2Cl and the NaCl cotransporters are the major players here. These are also where the loop and thiazide diuretics will have effects, and blocking these channels will increase distal sodium delivery. Knowing these channels will help you start talking about medications and their mechanisms of action, and knowing the location will also help you predict their side effect profile that we can see in clinical practice. In the last part of the kidney, sodium reabsorption becomes hormonally regulated, primarily through the action of aldosterone. This is where fine-tuning of sodium reabsorption takes place. Recall from your previous blocks that aldosterone is produced in response to a volume-depleted state or a high potassium state. It is the volume-depleted state that will likely cause us to want to reabsorb and preserve as much sodium as possible, and hence will activate the activity of the ENaC channels to reabsorb as much sodium and subsequently water as possible. If we are in a volume-replete state and we have too much fluid in our body, our aldosterone production shuts off, leading to a decrease in ENaC channels, and hence a decrease in sodium reabsorption. We will have more to say about aldosterone and this mechanism when we discuss potassium regulation in the kidney, but know that this is one of the major primary mechanisms behind the fine control of sodium homeostasis in our body. Finally, I wanted to discuss water regulation in the cortical collecting duct as the final aspect of sodium handling, given that both water and sodium are inextricably linked. Water is essentially reabsorbed with sodium, so the majority of water is reabsorbed in the proximal convoluted tubule, and follows essentially the percentages of sodium reabsorption in each area of the kidney, aside from the loop of Henle, where we recall that the descending limb is impermeable to solute, but permeable to water, whereas the ascending limb is only permeable to solute and not to water. At the last stages of the collecting duct, water excretion is finely tuned to finally form our urine, and it is at this stage that sodium and water reabsorption are hormonally controlled. Remember that sodium reabsorption is mediated through the activity of aldosterone, and water reabsorption is mediated through the activity of antidiuretic hormone, or ADH, otherwise known as vasopressin or arginine vasopressin, or AVP. While the collecting duct is only responsible for reabsorbing a minuscule 3% of the water, this can be the difference of peeing out 1 liter of urine versus 4 liters of urine, since we filter over 144 liters per day. I'm sure we all have felt the difference between needing to pee once a day versus 5 times a day if we drink too much water. So remember that it is this last portion of the kidney that ultimately determines how much water we excrete versus how much water we need to maintain, despite its seemingly likely such an insignificant amount. Let's take a closer look at where ADH acts on the principal cell of the cortical collecting duct. The high ADH or AVP is produced usually in response to high serum osmolality or low blood volume states. These two states, where you would think it's necessary to conserve as much water as possible, hence the term antidiuretic hormone. The ADH molecule attaches to the V2 receptor on the basolateral side of this cell. This stimulates intracellular responses that eventually lead to the production and translocation of aquaporin 2, or AQP2 channels, that are ultimately responsible for allowing water to quickly enter the cell and be reabsorbed from the filtrate. You can liken the AQP2 or aquaporin 2 channel to a door for water to enter, but this doesn't necessarily mean that water will enter that door. An osmotic gradient must be present to move that water, and this is achieved through the medullary concentration gradient. The formation of the medullary concentration gradient sets the stage to allow a high osmotic gradient for water movement into the cell when the aquaporin channel is open, allowing for reabsorption of water in the presence of high ADH or AVP states. The intermediate steps in this process are not important to remember, but you should instead focus on the main players highlighted on this slide: the V2 receptor and the aquaporin channels that will allow water entry. I wanted to talk more about the two types of diuretics here, which work on the loop of Henle and the distal convoluted tubule, since we are on the subject of water handling. This will also help us synthesize what we know so far about sodium and water regulation in the kidney. As I had mentioned before, loop diuretics are medications that act by blocking the NAK2Cl transporter in the thick ascending limb of the loop of Henle, hence the term loop diuretics. The diuretic effect is due to the increase in distal sodium delivery, which results in less water reabsorption. Remember, where salt goes, water follows. Thiazide diuretics will also block the sodium chloride transporter, but this time in the distal tubule, which results in an increase in distal sodium delivery and, again, less water reabsorption. One key difference is that loop diuretics will eventually disrupt the formation of the medullary concentration gradient by inhibiting that reabsorption of sodium in the ascending limb of the loop of Henle, the activity of which is crucial, again, to the development of the medullary concentration gradient. On the other hand, because thiazide diuretics are not affecting the limb of the loop of Henle, the medullary concentration gradient remains preserved. Why is this important? This is important because it explains one of the major side effects of thiazide diuretics that does not occur with loop diuretics. Because the medullary concentration gradient is disrupted, that shove that brings the water through the aquaporin 2 channel, the water reabsorption is impaired with loop diuretics, but not with thiazide diuretics, which can result in more salt loss, but less water loss than expected in the case of thiazide diuretics, since the cortical collecting duct will want to reabsorb as much water as possible in the setting of high ADH states. In clinical medicine, we look at the sodium concentration in the serum, which is a ratio between the amount of sodium molecules in the body and the amount of water we have in our body. If both the amount of sodium salts and sodium and amount of water losses are roughly the same, then the serum concentration of sodium should not be different. This is similar to the phenomenon that we see at the beginning and at the end of the loop of Henle, where at first water is removed and then followed by salt removal to result in a salt concentration that is almost the same despite removing both salt and water. However, if we're able to reabsorb water due to the presence of a very strong medullary concentration gradient, then you can see that the sodium concentration will actually tend to fall, with the denominator of water in the body becoming larger, even if the numerator in the salt stays the same. This ultimately leads to a lower sodium concentration in the serum, which we call hyponatremia. This is unfortunately a very common side effect of thiazide diuretics that results in many hospitalizations every year, especially in older patients with polypharmacy. Lastly, I'll leave you with a question that relates to a medication that we use in nephrology to the basic physiological principles that you have just learned about. What is the effect on water reabsorption of a V2 receptor blocker, such as tolvaptan or conivaptan? Will it lead to higher water reabsorption, lower water reabsorption, or will it not affect water reabsorption at all? Pause this video here to think about the physiology, and when you're ready to hear the answer, click play again. The answer to the previous question is that these types of medications will result in a lower water reabsorption. Since ADH or AVP can no longer attach to the V2 receptor due to the competitive blockade, this results in a lack of production of aquaporin channels. Even though we may have a lot of ADH and we are in a volume-depleted state, water cannot be reabsorbed in the distal tubule without the presence of the aquaporin 2 channel on the apical membrane. Hence, this results in water bypassing the absorption process and is known as aquaresis. This effect is very helpful in the treatment of volume-overloaded patients, especially with low serum sodium concentration levels. Since this medication works at the very last stages of the nephron, sodium reabsorption is not affected at all, and only water is eliminated from the body, resulting in our serum sodium concentration going up. Now you know one treatment for hyponatremia. Let's take another minute to just recap the highlights of sodium and water transport again. In the proximal tubule, sodium reabsorption is driven by mostly two mechanisms: the sodium cation transporters, most importantly the sodium glucose transporter, as well as the sodium hydrogen exchanger. The ascending limb of the loop is where loop diuretics act on the NAK2Cl channel, while thiazide diuretics act on the NaCl cotransporter in the distal convoluted tubule. When it comes to the collecting duct, things get more interesting. Remember that the formation of the medullary concentration gradient is through the loop of Henle and the countercurrent mechanism. But its functionality is at the collecting duct, where it acts as the shove mechanism to drive water out of the tubules through an osmotic gradient. Aquaporin channels, or AQP2, is a door that allows entry of that water out of the tubule, and the V2 receptor is that lock on the door. The key that opens that lock is ADH, or antidiuretic hormone, that sets the whole process in motion and allows for reabsorption of water. We didn't really discuss the last hormone, aldosterone, in too much detail yet, but know that this also contributes to sodium reabsorption in the collecting duct. Since this deals with more potassium control, we'll delve more into this in our next video. Hopefully you have a deeper understanding of how sodium and water is handled in the kidney now. Thank you for your attention today on today's mini lecture on sodium and water regulation in the kidney. I placed a couple of links here with some excellent online resources for you to read and learn more about the pathophysiology of renal sodium and water handling, which hopefully will help you solidify your knowledge. Please join me in the next video as we explore how potassium, another very important electrolyte, is handled in the kidneys.